Welcome to the Behavioral Health Brief. I'm Jim Callahan, CEO of Turn Behavioral Health Services, an organization driven by one clear mission: improving lives. I often ask myself, is there anything more important than that? My belief is this: when improving lives guides our decisions, stronger systems and healthier communities follow. That is the hope behind this podcast. Today's episode is about mental health awareness, what it really means, what it doesn't, and how we move forward with greater understanding and clarity. Because while awareness has grown, misconceptions still exist, and those misunderstandings can shape how people access care, how they seek help, and how we respond as a community. We'll explore what it takes to move beyond awareness into action, into access, and ultimately into impact, including how models like the internationally recognized Assertive Community Treatment, or ACT model, help bring that care directly into the community. Joining us today is Dr. Laura Otis-Miles, Executive Vice President at Turn Behavioral Health Services, where she spent 15 years of her career with Turn, and she joined Turn in 2010. Her background is Residential Treatment Director with the Department of Veterans Affairs, supporting veterans experiencing homelessness and complex needs. Welcome, Laura. We're really glad to have you on the Behavioral Health Brief today. And let's talk about the journey into your work. Your path here is both personal and professional. What led you into this field?
Thank you, Jim. I'm honored to be here and participate in the Behavioral Health Brief. My journey began when I was young. I have two younger sisters, and one of my sisters has mental health and learning disabilities. And being the older sister, I was looked upon to help take care of my sisters and support them as both my parents worked. My parents did their best to take my sister to the doctor to find out what was going on. She was struggling in school. She wasn't making friends. And in fact, she was really harassed and bullied while at school.
Wow.
And she got misdiagnosed and bounced around different providers. And during her teenage years, she became one of those kids where it was like she didn't want to go to another appointment. She just refused to engage in treatment and move forward. And my dad at the time really looked at me as the older sister on like, what can I do at this point? He was in law enforcement. He had several positions within the San Francisco Police Department and had really instilled in me an interest in working in public service. I became really interested in psychology based on the experience of what I saw going on with my sister and what was happening to her and the impact that it took by the time that she was a teenager. And so from then, I decided to go off to college and major in psychology and social work. I went to the University of California at Berkeley, where I got my bachelor's degree. And then following that, I decided to go on for my doctorate, and I earned that at the University of South Carolina.
Wow, you went all the way across country.
All the way across country. University of South Carolina had a dual-focused doctorate on both clinical and community psychology.
Interesting.
And that really aligned with my interest in psychology and social work, because the community psychology piece was all about community mental health and working in the community and bringing services to clients, and how to do work that was early intervention and prevention, which is really what my sister didn't wind up getting by way of being bounced around between different providers and misdiagnosed. She really didn't get the early intervention that, in my opinion, she needed. So following University of South Carolina, decided it was time to come back home to California, and landed at University of California, San Diego for my predoctoral internship and postdoctoral fellowship. And through the work there, I did placement in the Department of Veterans Affairs at the VA Medical Center. And that began my work leading to my residential treatment director position, working with Vietnam era veterans. And I really found myself gravitating towards working with those veterans because they had challenges with navigating the VA system of care. And they also experienced stigma and discrimination coming back from, Vietnam that impacted their willingness to even engage and looking at how to navigate the VA system for care, or even going outside the VA system for care. And that really just resonated with me, with the experience from what my sister had gone through, and continued to motivate me to work in community mental health and progress my career. And following my time at the VA, I had the opportunity to come to Turn Behavioral Health Services. 15 years ago, I started as a vice president, and I've had a couple of different positions within the agency, as you know about. And currently, I have the honor of overseeing several divisions of our mental health and substance use treatment programs in San Diego, as well as all the way back up to the San Francisco Bay Area, where I'm originally from and started my journey.
Interesting. So let's go back. What comes up for me is there's a moment in time when you were experiencing with your family what your sister was struggling with that put you on the journey all the way through your doctorate and where you are today. What kept you motivated? I mean, because that moment in time has brought you to today. And it's still, I'm sure, is something that comes up for you when you think about it. So describe that feeling and that momentum and that motivation that came from that moment in time.
Well, I would say that I found the work to be extremely fulfilling and rewarding. So it does go back to the people along the way, not just, my coworkers and colleagues, but, really learning from the clients that I've served, over the course of time, and really wanting to have, an impact. My affiliation with the mission of Turn to improve the lives of the individuals, families, and communities we serve is what keeps me motivated. And by continuing to do this work, I get to have that, reward, every day.
Yeah.
And as an executive VP, I'm really fulfilled by investing in our workforce, by being able to lead and, create that impact at scale with our teams. Means that by them feeling empowered and supported, they're going to deliver better care to our clients and families, and better care means better outcomes.
Yeah. I wanted to touch base real quick on the veterans component. How did you feel when you watched Sheldon on our initial podcast offering, when you saw him share his story about PTSD? Was that really compelling for you to bring back the days that you worked at the VA when he started to share? After 30 years, he didn't know he had it. And one clinician and a primary doctor diagnosed him and changed his life. So just maybe share of some of your experiences at the VA.
Yeah, that story that he told was so powerful. I'm pleased you brought that up, because that was the first airing of the behavioral health brief. And when I was listening to the podcast, it did remind me of so many of the veterans that I had the honor to serve at the Department of Veterans Affairs. The residential treatment program where I worked was actually based at the Indianapolis VA. So I did do a few years in the Midwest, before coming back again to California to open up their residential treatment program called a domiciliary. And we were serving veterans returning from the global war on terrorism, Operation Iraqi Freedom, Operation Afghanistan Freedom. And it really, for me, was really being aware of the differences of those returning veterans in terms of what they received. They didn't have the same stigma that the Vietnam veteran era veterans did. And currently, with our operation of the Courage to Call program, we see the similar dynamic of having younger era veterans coming into the program as well as the older Vietnam veterans. And Sheldon's story about how long it took him to be appropriately diagnosed and engage in treatment services is what we see more often than not.
Wow.
So continuing to do, outreach in a way that brings the services to where the clients are, by creating a phone number that they can call, by staffing the program with veterans themselves or family members of veterans, also makes a difference because it really helps sort of open up the doors wider for them with acceptance without stigma and discrimination of what they may have experienced.
Some of what Sheldon said, which really stuck with me, was I didn't realize that the nightmares were PTSD. And it took me 30 years to figure that out. And now, almost like he said, my life is whole again. So just amazing. So that's really some great experience. What does this industry that you're in and that we're in, behavioral health, mean to you?
I find the behavioral health field, to me, fundamentally means restoring hope, dignity, and the possibility for people's lives. It's about coming alongside and walking with them through their journey of recovery and empowering them with honoring their lived experience. As a leader, the behavioral health field is also for me about a call to action, which is supporting those that are the most vulnerable. And that goes back to the need for community-based mental health and substance use co-occurring disorder services. And by investing in our workforce, we're creating environments where both the clients that we serve and the staff that we have on board to thrive.
What really drives your purpose in all this?
My purpose and passion are driven by my personal and professional journey. As I shared from, when I was young, as a firsthand witness to the challenges presented by my sister's conditions and the impact it had on her and us as a family. And so from a young age, that perspective shaped my understanding and drove my path into psychology, which continues to ground me in the work that I do to this day. So I'm also passionate about leading in a way that is framed within the broader responsibility of how to bring that impact to scale by developing programs, systems, and teams that can meet the need and achieve our mission of improving lives of the individuals, families, and communities we serve.
If you don't mind, talking about your sister and then her journey, because I know your sister, you've talked to me about your sister, so maybe you could share with our audience today, how is she doing? What was her journey like while you were going through your journey and your education and stuff? How was that journey for her?
Yeah, I am proud to say that my sister is doing extremely well. My other sister, who's also in the behavioral health field, followed in my footsteps. She became a licensed professional clinical counselor. And we talk all the time about, between her and I, we were both, my other sister's, employment and job coach. Because one of the things that was important to my family was how to ensure that my sister was, building a life that gave her a sense of meaning and purpose and connectedness. So even though she didn't have the peer relationships and friendships and social network that me and my other sister have, we had to help support her in building that. And through her obtaining some schooling, she got her associate's degree at our local community college. And then I'll give a shout out to, which has been one of our community partners, Safeway, or Vaughn's here in San Diego, has been her employer for almost 20 years. She's a courtesy clerk.
Wow, that's amazing.
Yes.
Quite the journey for her as you were doing your journey. That's terrific. Now, your other are you the oldest?
I am.
So your other sister followed you. Said, well, if she's going to go get her psych degree, then I need to be doing that similar vein. So
absolutely.
Interesting. Well, that's really great. Our next area of focus today is going to be Mental Health Awareness Month. For those of you in the audience don't know, May is Mental Health Awareness Month, established more than 70 years ago, raises awareness around reducing stigma, encouraging early support. But there's still misconceptions that are out there, and we'll talk about those myths in a few minutes. But Laura, if you could share what Mental Health Awareness Month means to you in your role as the EVP at Turn Behavioral Health Services.
Mental Health Awareness Month means to me an opportunity to highlight the importance of engaging in stigma reduction about what it means to have a mental health illness. And these days, we know that there's co-occurring substance use disorders as well. And one of the things that I like to take the opportunity to do when wearing my green ribbon,
which is about today.
Yes, you've got yours, I got mine, which for me represents hope, growth, renewal, and really joining with the community to support individuals with mental illness and co-occurring substance use disorders in their recovery journeys, to not be ashamed by that, to stand up and advocate for meeting the needs of the community, whether that be with advocacy for funding opportunities or individual connection with being able to help somebody in need. We know that, there's a lot of people that are struggling in silence that haven't necessarily reached out for help. And so part of Mental Health Awareness Month provides that opportunity for, many agencies to provide outreach on numbers to call, access to services, whether it be suicide prevention or Courage to Call.
Right.
Peer helpline, serving our veterans and our military families.
Maybe you could also describe what we do internally for our participants and clients on Mental Health Awareness Month, because we're going to talk later about the number of programs that we operate. But what is it that we do for our participants and clients to make them aware or feel more comfortable with where they're at, especially with some of our clients who do have co-occurring disorders?
Well, many of our programs operate, services on site at the programs and then out in the field. And we do a lot of distribution of the green ribbons to support their hope and growth and renewal, to, again, join with them and walk alongside and be with them to support their, recovery journey and honor their lived experience, creating opportunities for our clients to share their stories, whether that be within, a treatment and rehabilitation group or another speaking opportunity. Looking forward to the behavioral health brief, taking advantage of the connection we made with our clients to bring some of those with lived experience on, who may be graduating from our programs. We have a lot of graduations typically at this time of year as well that align really nicely with Mental Health Awareness Month.
In fact, we have a graduation tomorrow night.
That's right.
For Turn to Recovery.
Turn to Recovery.
As graduation. And so those are always so compelling. All the graduations that we do across our company when we have them, that just makes the hair on my arms and my back stand up, and it makes me so proud when we see all of those clients that graduate. So maybe what we do now is we'd love to talk about some of those myths. And I'm going to ask you a couple of the myth questions that we hear out there about mental health. One I hear often is that mental health issues are rare. From your perspective, Laura, is that accurate?
That is not accurate. I want to start by talking about why there is a myth that mental health issues or mental illness is rare. That comes from the history of people with mental illness being institutionalized or being within families where there was an effort to keep those kinds of challenges secret and held back from public view. But what we know now in terms of busting that myth is that 1 in 5 adults experience mental illness within a year, and 50% of Americans will experience a mental illness within their lifetime.
Really? 50%?
So
of our population in the United States is going to experience a mental health issue
in their lifetime.
Wow.
And so
that's a huge statistic.
Yeah. So mental illness is not rare. What's rare is the experience of those with mental health conditions and co-occurring substance use disorders feeling comfortable about speaking about their experiences publicly. That's more rare. Although with Mental Health Awareness Month and other opportunities to advocate against stigma and discrimination of those with these conditions, you're finding more and more efforts to have the rarity become publicly more, less rare by way of more advocacy and communication.
Well, I think COVID really brought mental health awareness to the forefront. In everything
That's
that
a terrific
we do.
example.
I mean,
absolutely.
When everybody was locked up and stuff like that, and I think that's when we saw an emphasis as an essential service provider to really the need in our communities for mental health. Because maybe you could describe. I'm not so sure. I can't think of the right term to ask the question in this, but how does mental health not come about, but how do you recognize it? For somebody out there who may not know, like last time I asked Sharon about getting stuck. So what's the simplest diagnosis of mental health that somebody may experience? Can you describe that?
Well, I would say for family members, and I think I'll target this response to families that have children and youth and teenagers in the home. Because when you brought up COVID-19 pandemic, that reminded me that probably the largest area of impact we saw in the community with communication about mental health awareness and how to intervene and prevent problems from exacerbating was in the youth community because, children weren't going off to school, and that impacted their ability to keep their friends and engage in social activities that's so important for the development, of our children and youth. So I would say that it's just important for observation. And typically one of the things that can be noticed is just a difference in behavior and engagement. Usually folks that are struggling will withdraw and maybe isolate more, particularly youth and teenagers. And we could have probably a full podcast on the impact of screen time and social media and how that's pulled, children and youth from, again, more the pro-social and active engagement in school life, after school life, that can really continue to support their trajectory towards, success.
It's funny that you mentioned that because, or it's not funny, I shouldn't say it's funny, but I was approached by a father of a son, or his son, and he said, going into COVID, everything was great, right? Or before COVID, he was the star of the baseball team, he was straight A's and everything, but coming out of COVID, I need help, Jim. He is no longer interested in baseball. His grades have fallen off and suffer. He's not engaging with his friends the way he was engaging, and I really need some help. Where can I go? And I was hearing that multiple times from families, and then I guide them to some of our folks in the programs to be able to help them, guide them to the next step. But just you bringing that up brought back to me that whole, I've had probably 4 or 5 families reach out and just say, I need help. This is what's happening. I didn't realize that could be a form of mental health, what you just described and then the family I described. So interesting. How about myth number 2? The assumption most people who need help are getting it. What's the reality there?
Yeah, the reality is that about half of people with a mental health condition and co-occurring substance use disorder don't access services and get the treatment they need. The myth is based on the perception that because there's been increased access to healthcare, like, for example, the Affordable Care Act, which created more individuals to gain access to Medi-Cal benefits in the state of California, or parity laws with insurance reimbursement being like equal for mental health treatment alongside physical healthcare treatment, created this myth that, if the services are there, that people are getting the treatment that they need. But the reality is there's a gap. And about half aren't getting the treatment that they need. Now, there's a combination of factors as to why not. It may be related to insurance and ability to pay.
To access the programs, right?
Correct. Right. Based on eligibility criteria, and some services require insurance. As you know, and the work that we do at Turn, we primarily serve individuals with either no insurance or Medi-Cal.
Right.
So there's that.
The most underserved in our community.
Absolutely. And therefore the most vulnerable and most at risk. But there also is the impact, which I talked about earlier, about stigma and discrimination. Some individuals and families don't access care because of the fear of that consequence. And then we also have to keep in mind that not all services are gender responsive or culturally appropriate. So, we know that within different cultures and families, there's also views about what does that mean to actually access care that might withhold.
That kind of brings us right to myth number 3. There's also a belief that treatment doesn't really work. What would you say to that?
Well, there's plenty of research that shows that behavioral health treatment, especially treatment that's delivered based on the evidence-based model behind that treatment, has shown effective. Therapy, which is like counseling services, when delivered appropriately, typically have about a 75 to 80% effectiveness rate. When you combine therapy and counseling with medication treatment, so psychiatric medications prescribed by a psychiatrist or a psychiatric nurse practitioner, many of whom work in our Turn programs. The combination of the medication treatment increases the effectiveness rate up to about 85 to 90% for a condition like depression.
Right. Get them housed. Get them to meet with the doctor. Get them as much as we can get them on their own in their living environment, and we have the making of success. Interesting. How about myth number 4? Sometimes people think mental illness is a personal choice or something someone can just push through. How do you reframe that? Yeah,
and the underpinnings of that one historically date back to perception of if you just pull yourself up by your bootstraps.
Yeah, that old adage, right?
You'll be okay. And that, again, with mental health conditions being kind of kept secretive in the family, then there's an expectation that, someone just needs to be, trying harder or, being more self-reliant, push through, pulling themselves up. But the myth is that, for personal choice, no one chooses to have depression, PTSD, schizophrenia, as we talk a little bit more about more serious mental illness conditions, just like no one chooses to have diabetes.
Yeah.
So it's that, mental health conditions are medical conditions that can be treated. And there's the, biopsychosocial research behind that to show that treatment is effective, as I mentioned in the example regarding depression. Interesting.
So before we close out today on just this portion of the program with regards to Mental Health Awareness Month, there's one last myth, and it's there's still stigma around substance use. It's a moral failing rather than a health condition.
Right. That's another common myth right alongside mental illness being a personal choice. The history on that goes back to the criminalization of addiction and the war on drugs and the high level of stigma and discrimination that came about in society when individuals with substance use conditions were labeled as addicts. And it's, related to not being a moral failing. It's countering the perception that someone with a substance use disorder has poor decision making or a difficult character, making bad choices. Again, like mental illness, substance use condition is a chronic medical condition that there's effective treatment for. Harm reduction strategies, medication-assisted treatment, and what we know about, also the self-help community too, in supporting individuals with engaging in care and participating in their recovery.
Anything else you'd like to share on Mental Health Awareness Month before we move on to our brief and break?
Just that I hope everyone's got their green ribbons and is wearing them proudly.
We're going to continue this conversation in just a moment, but before we do, it's time for the brief, where we highlight a current event shaping behavioral health. And today's event that we're going to talk about is California Transformation Effort, Prop 1 and B-CHIP, and expanding treatment beds, housing, and facilities, and addressing the need for capacity gaps. We've tried to experience this ourselves at Turn, where we tried to apply for some B-CHIP funding to be able to convert one of our facilities that's a women's residential treatment into a male residential treatment using the B-CHIP money. But that wasn't very successful for us because they wanted us to sign a 30-year easement on the property that only behavioral health would be served out of those buildings during the time that they loaned us the money to be able to develop. And I said, well, we can't do that as a nonprofit because at some point in time we're going to want to sell the building. And if we can't sell it because nobody wants to buy it because it has to have behavioral health services, so it was kind of a self-defeating proposition for us. But it's been really good for counties because counties can dedicate the land, they can dedicate the building, they can remodel the building, and they can put behavioral health services in it. So the B-CHIP for the counties, especially the rural ones, has been very successful. And it's also strengthening infrastructure and access over time. But Laura, if I'd hand it off to you for a minute, how do the efforts like this impact care on the ground through Prop 1 and our B-CHIP process?
Well, the passage of Prop 1 is a step towards putting policy into practice by building treatment capacity and housing. What we know is that clients with serious mental illness and co-occurring substance use disorders often wind up in psychiatric hospitalization or in incarceration as a result of behavior and criminal activity associated with the mental health or substance use condition. And these individuals, when they're discharged from care back to the communities, need housing. And we talk all the time about how there's a shortage of affordable housing in our communities. And Prop 1 and B-CHIP funding is an effort towards bridging that gap, putting that policy into practice. For providers like us at Turn, it's also an effort at building more of a continuum of care.
Right.
So that there is the treatment capacity for clients to receive the inpatient care that they need and then have housing as an outpatient with community-based services. The other part of what the impact on the ground is like for the passage of Prop 1 is that for providers like us as well, there is an increased accountability on outcomes and data-driven results that connect back to additional opportunities for funding. So it really raises the bar on holding accountable those providers to be able to earn that funding and be able to continue the services moving forward.
The interesting thing with Prop 1 and B-CHIP, I don't know many CBOs like us that are actually investing in it. They may be taking the benefit of it by working with a county that has a facility. As I think when I was at the CSAC conference, this was last December, it's been a while ago, but it's the California Association of Counties. A lot of the rural counties took advantage of the B-CHIP so they could develop a treatment facility for them in the county to be able to have people suffering from mental health. And I was talking to the rural counties. They said, but we don't have the staff. We'd love for you guys to come up and meet with us because you could provide the services while we provide the building. So that was the synergy that I saw between Prop 1 and B-CHIP. And I think the governor, when this came up and Prop 1 passed, I think he put $25 billion towards it. It was a huge amount of money for the B-CHIP. So there's some good things and there's some maybe not so good things for CBOs under Prop 1 and B-CHIP. But
and you brought up workforce shortage.
Yeah.
That's a current challenge, and that's where we, as a provider, community-based organization, CBO, help fill the gap because we invest in our workforce and grow them and develop them to do this work in the interim, because we know that building infrastructure like facilities for treatment capacity, beds available for the clients that need that highest level of care, and then housing as they come out into the community takes time.
Yeah, it does. You're exactly right. And for our audience out there today, I definitely, if you haven't really looked at Prop 1 or B-CHIP, I encourage you to look at Prop 1 and B-CHIP. There have been 2 rounds of funding. We haven't heard that there's going to be a third one, but if round 1 and round 2 are successful, I would bet we'd have a round 3 of funding because of round 1 and 2 being so successful in the communities, with also treatment and housing. So with that, we're now going to have a brief word from Turn Behavioral Health Services, and we'll be right back with you. We're headed into our commercial break.
Improving lives every day and in every way for Californians. This is the mission of Turn Behavioral Health Services. By focusing on wellness, recovery, and resilience, Turn is helping create lasting change, especially for our military community. If you're active duty, a veteran, reservist, regardless of military status, or part of a military family in San Diego, support is here. Courage to Call is a free, confidential helpline staffed by veterans who understand military life. From 8 a.m. to 8 p.m., you can connect with peer-to-peer specialists who are ready to listen, guide, and help on the very first call. Struggling with mental health, food insecurity, finances, housing? You don't have to face it alone. Call 877-698-7838. That's 877-698-7838. Courage to Call will answer your call. Courage to Call is a program of Turn Behavioral Health Services, improving lives every day in every way.
Marsh McLennan Agency, a business of Marsh, is a provider of business insurance, employee health and benefits, retirement and wealth, and private client insurance solutions across the U.S. and Canada, with several locations across Southern California. To learn more about Marsh, a trusted advisor around the world with expertise in risk, strategy, and people, please visit marsh.com.
Okay, so welcome back to the Behavioral Health Brief. I'm Jim Callahan, and we're continuing the conversation today with Dr. Laura Otis-Miles, Executive Vice President with Turn Behavioral Health Services. Let's pick up where we left off, and let's make our spotlight now on assertive community treatment, designed to meet people where they are, providing ongoing community-based support. What is ACT? And who is it designed to serve, Laura? That's my question for you today on the ACT.
Great question to get us started. Assertive Community Treatment ACT is an evidence-based model that is endorsed by the federal government, which is the Substance Abuse Mental Health Services Administration. SAMHSA. And it serves individuals that have serious mental illness, co-occurring substance use disorders, and individuals who are at risk for homelessness, institutionalization, or incarceration.
Interesting. So what sets it apart from other modalities of service that we deliver in our book of business?
ACT is unique in that it is delivered in the community. 80% of the services are delivered in the field. Traditional mental health services, you could imagine, involve clients coming in to the office for an appointment and coming in at a frequency that would be maybe at, once a month or once every 3 months. ACT is about meeting clients where they're at in terms of the level of care that they need by an interdisciplinary team. I often describe ACT as a hospital without walls.
That's right. I remember you saying that.
Rather than the client coming into the clinic for an appointment, it's designing the services to go out into the field to meet the client where they're at. And so this could be out at a homeless shelter or an encampment, or if a client has housing, in their home. It also could be on a street corner, depending on the situation.
Would that include a doctor or nurse practitioner that would be on that team when they're out in the community?
Absolutely.
So that he could immediately administer medications if he needed to, or the nurse practitioner could?
Yes.
Wow,
yes.
Interesting.
And we have ACT psychiatric prescribers who have given injection shots on the street corner.
Right. And I think also, looking at the number of services that we supply, we run a number of ACT programs. In fact, one in almost each of our 7 counties, in fact, more. How many is it? We're running 4 ACT programs and 6 ACT programs.
6 ACT programs.
Go ahead, share it. You're the ACT expert.
6 ACT programs in San Diego County, funded by Behavioral Health Services. We have an ACT program in Kings County, up in the Central Valley, alongside Fresno. We have 2 ACT programs, and last but not least, we have an ACT program in Santa Clara County, up in the San Francisco Bay Area.
Right, and that just to take a minute to maybe, guys, we call it off script, but Laura and I were involved in getting that program off the ground up in Santa Clara, and the challenge with that ACT program was it was literally right at the beginning of COVID. And so we won this new program, 100 clients that we're going to get, and it's COVID. How do we deal with COVID and clients? And we launched this program, and we had 22 to 25 brand new employees to the program, and we couldn't go see them because we couldn't get on an airplane. And in fact, Laura and I, the little short story here, we're up meeting with Santa Clara County, and we had to get to the airport to get on our plane. We got on the plane, landed in San Diego, and that night, if it wasn't that night, the next morning, Santa Clara County went into lockdown, and nobody could go anywhere. So we kind of made it out in the nick of time on that COVID, but it was extremely challenging. Maybe you could just share real quickly what some of the challenges were for that ACT program specifically in engaging clients under the ACT model, because COVID took the lid off on ACT, right?
Right. So. And we at Turn brought the evidence-based model of ACT to Santa Clara County, as funded by our Behavioral Health Services Department there. And the intention was to have clients be discharged out of long-term psychiatric care into community-based housing, which we were also positioned to provide with the new contract by way of doing master leasing, where we would master lease a home and then sublease to our clients coming out of inpatient care. But because of the COVID-19 pandemic, the decisions were made to keep clients hospitalized and continue on their institutionalization, because these were clients that were in these treatment beds for upwards of 2 years or more, and many of them were ready to come back out
and come out
into the community and receive our hospital without wall services, but the pandemic slowed that process. So in the meantime, we took advantage to invest in our workforce and provide a lot of education and training on the model, because it is unique. There's criteria to it that make it a specific set of interventions that we provide that all need to be, coordinated and managed on a daily basis.
Right, and I think this is it's one of the specialties at Turn Behavioral Health Services that we're so adept at, is dealing with these ACT programs and dealing with the clients and making them successful. If we talk about outcomes for a minute, what do you see when ACT is working well?
When ACT is working well, we see clients that are more engaged in treatment. Because we take the services out to the clients in the field, it limits the ability of losing them along the way due to other barriers like transportation problems with like coming into a traditional setting. And again, many clients aren't comfortable coming into a traditional setting. So because of ACT providing that with the multidisciplinary team, we see them more engaged. The other part of assertive community treatment that I like to explain with the assertive in the name of the model is that the treatment is persistent. So it's a do whatever it takes, never give up model. And so we keep going. Even when clients don't want to engage with us, we keep going. And on the team, we include individuals on staff with lived experience. And these are individuals in peer support specialist or family support specialist positions, individuals that have their own personal lived experience of having a mental health or substance use condition, or maybe even being homeless and recovering from that. And they use their lived experience to tell their story, to engage clients, which we know can be so meaningful and powerful for making that connection. That increases the trust and confidence in us as a team to provide these services to the clients. And we also don't limit the time frame of which the services need to be delivered that you might see in a traditional setting where someone might have only 10 to 12 therapy or counseling sessions. This is essentially tailored to meet what does the client need. And the contact frequency is high, up to 4 times a week, or even every day if needed. And so that increases stability. And we see, and this is where the research on the outcomes shows that there's less rehospitalization or incarceration back to jail by way of the intensity, frequency, and longevity and the persistence of the assertive community treatment model.
Very interesting. Could you just, there's always been this other component to the ACT program called High Fidelity ACT. Can you describe that real quickly and how that fits into the overall ACT model?
Yeah, high fidelity, we talk about a lot amongst our teams, but for our listeners today, they might not know, what does that exactly mean and why does it matter? The model has about 40 years of research behind it. And the research results are very consistent in showing the effectiveness of the model, reducing hospitalization and incarceration and stabilizing clients out of that cycle of, relapse, readmission, discharge, relapse, readmission. And the research shows that the model being delivered to the requirements of the model per the highest fidelity. So it's really prescriptive. And there's a tool, several tools have evolved over the course of time. One is from SAMHSA. But we follow the tool and are evaluated, this goes back to outcomes, on how well are we delivering the model according to the requirements of the fidelity tool. And it matters because operating the program at higher fidelity means better outcomes.
I can remember being in some of those meetings when the annual report would be put out, like the example when we were in Contra Costa, and that report was so successful for us because we were hitting all of our high fidelity markers. So that meant we are servicing more people and they are no longer suffering, which was just great to hear inside that act. So where do you see, we'll probably take another podcast to talk about the Laura's Law tie-in and that model. But where do you see ACT going in the future? What's the future of, you mentioned around 42 years that ACT model's been around.
Yeah.
What's the future for ACT?
Yeah. The future for ACT is extremely promising. The research continues, but the funding also continues. And what we're seeing at the state and county level is more funding going into the programs that are intensive, community-based, have the interdisciplinary team with the multiple disciplines included, and that really operate around the clock, the 24/7 piece of the service model and the housing that goes with it. So I foresee that the focus of ACT is actually going to continue now to be also where does ACT come in and how does it assist with the opioid epidemic and how to use the ACT teams even better than we already are for Narcan distribution to literally help save lives out on the street, because we have clients that have co-occurring substance use disorders that struggle with opioid use, access to opioids and other high-risk substances on the streets.
Wendy just reported on one at the last board meeting called Khartoum, I think it is.
Kratom?
Kratom.
Yeah.
Kratom. And how available that is in our communities.
Yeah.
You could buy it right at a 7-Eleven store, but it's a killer.
Right.
That's really sad.
Right.
So it's really interesting on that. Anything else that you'd like to share about ACT? And is there anything that ties in with Mental Health Awareness Month and the ACT model, or anything to share from that standpoint before we transition?
Well, one of the things that I want to mention is in regards to ACT as an evidence-based model, we operate at high fidelity, and we have such strong results and outcomes from our programs. So shout out to all of our ACT teams working for us.
Big shout out there.
Yeah,
They're really delivering.
Absolutely. Is that we're seeing even better outcomes when there's a co-located substance use disorder treatment track alongside it. So the multidisciplinary team of an ACT team includes substance use counselors. But to be able to provide even more tailored and flexible pathways for engagement of individuals into substance use treatment specifically, we operate two in San Diego, one in Fresno, with an alongside substance use disorder treatment track. And that puts those services under the same roof. So we have sort of that one-stop shop opportunity, while at the same time being able to deliver services out in the community and provide the support of housing and recovery.
I'm really glad that you mentioned that, because Action Central and Action East and Dart West and
Fresno Impact.
And Fresno Impact all come to mind when we talk about that continuum of care under one roof. They can get services for mental health. They can get services for substance use, because most of the time they might be suffering. The clients may be suffering from both. So thank you for bringing that up today. But I'd really love to shift to one of my favorite parts of the behavioral health brief, and that's the community questions, okay? And so we're going to go into that part of that process this afternoon, and I think we have our questions right here, Laura. So go ahead and let me get the cup over here. Go ahead and draw a question right out of there. Get your first question.
Okay.
And these questions are from our employees.
That's right.
So,
and shout out to Lila from IT. She wants to know, what do you see for the future of Turn over the next 5 years?
Well, that's a big question, isn't it,
Yeah.
Laura? What do you see?
Yeah. Well, extending from our conversation about ACT and mental health awareness, I do see us as a provider, CBO, continuing to be impactful in providing the ACT level of care in communities moving forward. I also see that that's in alignment with where the funding is for creating that, treatment capacity and supportive housing. There's more of a focus now on housing being a platform for stability and treatment, as well as employment, where it's like housing and employment are considered treatment.
Right.
Because ACT isn't just about, treating the psychiatric diagnosis with medication management. It's also about treating and supporting success at daily life skills and all the other things that help keep somebody out of homelessness.
Well, that's what makes that ACT model work so well, right? Is the clients, we're supporting the clients not just on their, like you said, psychiatric.
Yeah.
It's the housing, it's security, it's the medication security, and
access
job
to benefit,
stability.
right, and access to benefits for those that
benefits.
Right,
So,
may not be on the trajectory for competitive employment. But I want to ask you, Jim.
Okay, ask away.
What do you see for the future of Turn in the next 5 years?
That's a big open-ended question. We're right now developing our strategic plan, but we're really only looking out 24 months because so much is changing, both at the federal level, here at the state level, with what's happening at SAMHSA, what's happening at HHSA in Washington, D.C., and trying to rework funding and some cuts of funding and stuff. I think this next year is going to be another transition year for us, this fiscal year coming up. But I'd like to see our growth, and what we're focusing on is more criminal justice through CDCR and DRP. I think we're really good at that. We've heard about that earlier today, but we have our men's program and we have our women's program of them coming out of incarceration, finishing their term in incarceration, and then being transitioned into the community. I think there's a big opportunity there for us because we do that really well. And I think almost all of the programs we're in, I think one of the things that's unique for Turn is that we're not just one modality. We're not just children or adult and older adults. We're not just criminal justice. We're mental health, substance use, criminal justice, veterans. And so that gives us the ability and flexibility to ebb and flow as funding ebbs and flows. But I think all of those categories are still growth categories for us. And we're going to have to pick and choose the opportunities that best suit and best fit inside our wheelhouse over the next 24 to 36 months. So that's how I would answer that question for Lila from IT. All right. How about question number 2?
Okay, also from IT, RJ asks, what's the most unexpected thing you've learned during your time at Turn?
The most unexpected thing. What was that question again?
What's the most unexpected thing you've learned during your time at Turn? For me, I would say that the most unexpected thing that I've learned is how providing the right treatment model at the right time does support clients' rehabilitation and recovery. Early in my career, when I was doing residential treatment.
At the VA, when we talked earlier today?
Yeah, at the Department of Veterans Affairs, the VA. I don't think I saw the pathway of success for clients coming out of residential treatment back then like I do now. And I really do think that that's because my purpose and passion and motivation for doing community mental health work and mental health awareness is from being able to implement through the opportunity at Turn, high fidelity, ACT model, and really increasing our expertise in doing that successfully with essentially saving the lives of so many of our clients.
And I think the key to that is we did it successfully miles from our headquarters at home. We did it, and we're still doing it in Santa Clara, Fresno, Kings, and delivering it because it's a challenge to deliver in each community. And each community is different with their own culture, own demographics, and geographics. We're getting to the clients. So really interesting.
Is there anything unexpected for you that you've had in your
what was that question again? What's
time at
the
Turn?
most unexpected thing you learned during your time at Turn? I think the most unexpected thing for me was when I first came to Turn
10 years ago.
10 years ago. But about halfway through that, we were really trying to develop our housing program and really do master leasing. And what was unexpected for me in that challenge, because I have a real estate background, we're leasing, we're putting clients in a building, right? How hard could that be? What I didn't realize is how the clients were really suffering with their mental illness or substance use and stuff. And for example, some client may tear a ceiling fan out of the roof of the unit because he thinks it's a spaceship. And so I underestimated the need of the clients thinking that just housing them was going to help. And so that was unexpected for me.
It's housing in combination with
the treatment.
To treat the psychotic
right, because
symptoms
we knew if we could treat the psychotic and we were getting them housed and getting them fed and back on medications, they'd be successful. But I underestimated how some of these clients could really be suffering from mental illness or co-occurring disorders. And so that was probably one of the biggest unexpected things that I've learned during my time at Turner. We had to shift, and I think we shifted well. Anyhow. So
great.
Question number 3.
All right. There we go.
Got it? You got it? Okay.
Angelo from accounting asks, as an EVP, what keeps you at Turn and what positive changes have you seen over the years? What keeps me at Turn after 15 years is I'm passionate about our mission and the impact that we make. I'm also deeply rewarded by working alongside such a mission-driven workforce as well. It's a pleasure and an honor to work with our staff, all our teams. We have rock stars.
We do. And sometimes we forget that, but that's why I love getting out to the programs and really meeting the boots on the ground people that are doing the services.
And you do an excellent job.
That's so rewarding. That's so rewarding.
Absolutely. And I think the positive changes over the years
let's hear that.
Are evidenced by the work that you've done, that we've done together in the last, decade or so. And the pride and investment we have in really acknowledging where there's, success to be celebrated.
Yeah.
And I think we're doing such an excellent job at that. I mean, I think back to during the COVID-19 pandemic when
Holy smokes.
We got a lot of positive feedback about the services we operated at the San Diego Convention Center.
Yeah, I'd forgotten all about those.
Right, the Counseling Corner.
Yeah.
That was a group of us, and we won some Healthcare Hero Awards from the San Diego Business Journal during that time.
Yeah.
And I think that, coming out of the other side of the pandemic and then being able to successfully grow Santa Clara Action, which started and struggled
in the
at
middle
the beginning,
of the pandemic.
Right? We have such terrific outcomes and support from our funders to this day at that program. And so the positive changes over the years are how we acknowledge success, how we celebrate it, and invest in our workforce to continue to commit to the mission of improving lives.
Yeah, and I think the big success over the 10 years that I've been here and seen is we continue to deliver top-notch services for all of the underserved in our community, and we get acknowledged for that. In every one of our counties, I think really well respected for the level of service that we deliver to all of them. But as we begin to wrap up this conversation today, Laura, I really want to thank you for being here today. This has been really another great learning session. Great to be back with you, and because we opened up some of these regions and had to close some of these regions together, which was sad. But we've really pushed behavioral health to a new level in a lot of the communities that we've worked in. But before we close, is there anything you'd like to leave with the listeners today as a takeaway for them?
Absolutely. In honor of Mental Health Awareness Month, I would like a call to action for our listeners, encouraging folks to, start a conversation or check in on someone, or for someone that may be struggling with mental health or substance use issue, to reach out and ask for help, because help is available.
Yeah.
And for community members and stakeholders, I encourage folks to learn about the services in their communities, advocate for ongoing funding, and continue to be of help and support and contribute, to the effort.
Yeah, that's great, because that's why we're doing the behavioral health brief. I want our community, and we're advocating so they know about the great level of services that we supply out there. But Laura, thank you so much. Really appreciate it. Now we're going to transition into the gratitude portion and close out today's behavioral health brief. So thank you for joining us, Laura. Sincerely appreciate it. And your 15 years of service have been tremendous. Thank you.
Thank you very much.
As I close today's episode, I want to pause and practice something essential to well-being and perspective, and that's gratitude. It's something I practice every day through a gratitude journal, and I encourage you to find a practice that works for you. My journal that I use every day and give thanks to everything in my life that I'm grateful for. I'd like to start by thanking the incredible staff at Turn. Your compassion and commitment makes this work possible every single day. I also want to thank our community partners. This work doesn't happen in isolation. It takes collaboration, trust, and shared commitment. We're grateful to work alongside you in strengthening the health and well-being of our communities. And to our funders at the federal, state, city, and county levels, your support allows us to expand access and continue reaching those who need care most. To our listeners, thank you for spending time with us today. Please like, share, and subscribe. As I close, I'll answer the question I open with. There's nothing more important than improving lives. And together, we are improving lives. I'm Jim Callahan. This has been the Behavioral Health Brief. See you next time.